see. These are my disclosures. So before we start off with the tips and tricks of deformity, I just want to point out how common it is. You know, up to 68% of volunteers over the age of 60 had some evidence of scoliosis. So in dealing with scoliosis, getting X-rays is very important. It's the foundation upon which we can identify the deformity. And there are many different pieces of information that we can learn from X-rays. So very important to order the standing long cassette X-rays on all of these patients. And it's not just the standing scoliosis X-rays that are important. It's important to look at the influence of position. So one of the tips for this tips and tricks talk is to evaluate, is to understand that you can't underestimate the power of positioning. You know, depicted on the left is the extensive coronal deformity that this patient has when they're standing. However, when they're supine, you can see to what degree things correct. She's almost a perfectly balanced coronal plane when the patient is supine. So just very important to recognize that position plays a big role. Also very important in terms of tips is patient selection. You should always try to enhance all aspects of the patient's condition prior to surgery and make sure they go through an adequate medical clearance. You want to ask some fundamental questions with regard to whether or not the patient has an adequate life expectancy and social support system. Do they have a good understanding of the surgery itself and the potential risk for complications? So we're just going to go through a few examples, and through each example, we'll go over a couple of tips and tricks. And this is a 59-year-old woman with a history of a former T2 to iliac fusion. The patient underwent a L2-3 lateral interbody fusion after the patient was found to have a pseudoarthrosis at this level. She initially did well, but then started to develop some progressive kyphosis and cauda equina syndrome. This is a sign of her profound positive sagittal balance. She had a substantial mismatch. She also had a significant sacral fracture, as depicted here. So what is the surgical plan? You know, this patient needed about 30 to 40 degrees of correction. So the plan was a 3-column osteotomy, and to address the fracture, extension down to the pelvis was thought to be most appropriate. But the key concept of this is when deciding on where to make the PSO, the PSO is less technically challenging at an area where no surgery has been done before. So in this patient, I chose to do the PSO at L1 because the patient had no previous laminectomy at that site and there was no scar tissue at that site. And you can appreciate what it looks like when there's no scar tissue. It becomes much easier to identify the anatomy. And when you close down the osteotomy site, you have less of a tendency for buckling of the dura in the scar tissue on top of the dura, which potentially could compromise the neurological structures. So you can appreciate the nice correction that this patient achieved and the restoration of the sagittal balance and the healing of that fracture. So another example, 74-year-old physician in the community who had a previous lumbar decompression. It was mostly a laminectomy, but he developed some worsening kyphosis and had severe foraminal stenosis. He was having back pain and leg pain. Whenever you have a patient who has residual foraminal stenosis after a standard laminectomy, you can reliably count on the lateral approach followed by percutaneous pedicle screws, especially when there's a concern for the patient's possible extensive blood loss and comorbidities. So a patient with morbid obesity could also be more effectively managed in this with this surgical plan. For this patient, he ended up deriving benefit from a lateral approach with the sectioning of the anterior longitudinal ligament to restore some of his lordosis. At this level right here, we were unable to gain access from the lateral approach because of evidence of neuromonitoring issues, and any placement of the retractor resulted in extensive firing. So we were forced to do a T-lift at that level from the posterior approach. But he still derived great benefit. This saved him from having a PSO and a more extensive tissue dissection. So you can appreciate that he had an improvement in his coronal alignment as well. And this is a 74-year-old patient, so he did not have the need for a complete correction, and he had satisfactory relief of the symptoms. Another example is a 55-year-old female with previous surgery and progressive back and leg pain. She had a mismatch of approximately 35 degrees. And one of the tips when evaluating the CT is to take advantage of the disc spaces that have gas, and also to take advantage of the disc spaces that have an angular deformity. You can see that this patient had an angular deformity at that L4-5 disc space, and there are ways that one can go about taking advantage of these disc spaces, and it doesn't always necessarily require a lateral approach. In this case, this patient had a posterior approach, and this expandable cage was placed preferentially on the side of the angular deformity collapsed side of that disc space. And this patient ended up having, as you can see, an improvement in that angular deformity with that cage interfacing with the lateral aspect of the apophyseal ring, and then providing plenty of opportunity for additional bone graft placement medial to that intentionally laterally positioned cage. So you can appreciate that this patient had a good restoration of her lordosis and improvement of her coronal imbalance, and did well. Again, just showing the magnitude of the before and after improvements. So the tip is to really take advantage of disc spaces with angular deformity and gas. So we discussed in one of my previous cases that the anterior longitudinal ligament is a powerful tool for deformity correction, and it can be performed on occasion during lateral approaches. But as I've learned, sometimes it can inadvertently be performed during a posterior approach when you're trying to really clean out the disc space. And seeing how this can potentially happen inadvertently, there are times where you can plan on achieving a correction similar to what one would achieve from a 3-column osteotomy by simply loosening the anterior longitudinal ligament from the posterior approach. And this was something that I inadvertently sort of came up with on my own in operating, and going back into the literature, I realized that it's been described by many other people. This happens to be a orthopedic surgeon in Missouri who reported his series. Dr. Sweet has very nice depictions of this technique where using a curette, he does a very thorough discectomy and a very thorough release of the annulus. And as you can see depicted here is a very significant opening of the anterior longitudinal ligament. The main limitation of this is the concern for the possible migration of this cage. But as you can see, there's compression that is performed, and you place the cage more posteriorly in order to be able to compress upon it with the residual end plates. So this technique I use from time to time, in particular, if the patient has a fixed sagittal plane deformity and there is a calcification of the anterior longitudinal ligament, you can essentially use that calcified ligament to your advantage to crack it and essentially indirectly open up the ALL without directly cutting it. Obviously this comes with the concern for the potential risk for vasculature, but if it's done indirectly without really violating it other than through the use of blunt instruments, you can achieve the stretching or cracking of that area with very minimal risk. So this depicts the technique of stretching the ligament, where you take this blunt dilator and you try to get very close to the ALL and maybe slightly past it, and you just maybe disrupt just a small portion of it, perhaps at the level of the midline where things are less likely to be present, and you'll see that you'll be able to get a lot more mobility. And even if you don't completely release the ALL, you just weaken it, it will help you with your corrections. This is an example of a patient who had this technique done at 2 different levels, and we improved the lordosis without doing a PSO. We went into this case thinking that a PSO might be necessary, but through this technique, we saved her from having that need. So the same is true for this operation, for this patient. This was not a release of the ALL other than through stretching of those areas. This is a interbody cage that we put in here and got a segmental angular improvement of that level, saving her the need for a 3-column osteotomy. Another example right here, this patient, we gave her about 15 degrees from that one disc base. And all in all, there's some benefits to this method because there's less blood loss and there's less kinking of the dura. You're therefore less likely to compress the nerve roots. There's less bone removal, and as such, less likely of having a fractured rod. However, this is not without risk. We are releasing the ALL or perhaps weakening it, and this is not under direct visualization. So for that reason, I don't recommend it. Unless you can use blunt instruments to just weaken. I think the goal mostly should be to weaken the ALL and not go through it. And I think if you use blunt dilators, you can achieve a much better T-lift than you normally would be able to achieve. So in conclusion, there are a wide variety of treatment options for scoliosis, and patient selection plays a vital role in this, and it's the treatment strategy of the surgeon is based on his or her previous experiences and what is best in his or her hands. Thank you very much.
That was great, Charlie. Wanted to know if there were any questions at all. I have a few. One has to do with Charlie. I know just from history and practice in Baltimore that you do not always have the opportunities to optimize nutrition before somebody presents with significant neurological impairment. But what are some of the things you do post-op, sometimes even starting in a hospital, that helps with that?
Yeah, so post-op, we certainly can get some advice from nutrition and from actually our plastic surgeons. One of our plastic surgeons has an interest in post-op nutrition, and sometimes we consult her. Rarely, sometimes we need to resort to TPN But most of the time, we succeed in having successful wound healing with consults from our plastic surgery colleagues. And for someone who's really at risk, sometimes we have plastic surgery do the closure, and that way we can not only use their surgical skills to help improve wound healing, but also their knowledge of nutrition.
That's good. What about the use of the expandable cages? I could see that you're using it for sort of laterally expanding disc height. Would you say that's changed a lot of how you do things now, saving yourself from maybe pedicle subtraction, osteotomies, or even anterior cages at all?
Yeah, I would say the combination of using those blunt probes to help dilate the disc space and help prepare the inner space in conjunction with the expandable cage. I think the combination of those two techniques will give you a lot of leverage. You know, Jens last year talked about his intradiscal osteotomy technique, and this is essentially the same thing, you know, where we basically go in, but the limitation of the cage is the quality of the bone around it. You know, so if you do an expandable cage and you don't release the tissue or the disc enough, you know, you're just going to get subsidence. The key is to do a release to the point where the vertebral bodies will separate from each other in a way that does not put too much stress on the end plates. And I think that the key is really not the expandable cage, but is the preparation of the interspace prior to insertion of the cage.
That's wonderful. Thanks, Charlie.
Thank you.